on advanced management of diabetes and its comorbidities. Now, this series is brought to you all by Care Institute of Medical Sciences, Ahmedabad, in association with Docplexus. Today's discussion is centered around how machine learning and artificial intelligence have given a new face and a new pace to our modern healthcare practices. Welcoming our first speaker for the day, Dr. Neil Mehta, who will be talking about machine learning and artificial intelligence in healthcare. Welcome, Dr. Neil. Requesting you to please start your presentation.
Hi, and welcome to this presentation on machine learning and medicine. In this presentation, we'll go over the differences between machine learning and artificial intelligence. We will then compare it to traditional statistics and look at a simple classification of machine learning. We will then take a look at some examples of machine learning in healthcare and finish up by discussing some of the limitations of machine learning.
Open the pod bay doors.
Open the pod bay doors now.
I'm sorry, Dave.
I'm sorry, Dave.
I'm afraid I can't
I'm afraid I can't do that.
What's the problem?
What's the problem?
I think you know what the
I
problem
think you know
is
what
just
the
as
problem
well as I
is
do.
just as well
What are you
as I
talking
do.
about, Hal?
What are you talking about, Hal?
This mission is too
This
important
mission
for
is
me
too
to allow you
important
to
for me to
jeopardize
allow
it.
you to jeopardize it.
I don't know what you're talking about.
I don't know
Hal.
what you're talking about, Hal.
I know that you and Frank
I know
were
that
planning
you
to
and Frank
disconnect
were
me,
planning to disconnect me,
and I'm afraid that's something
and I'm
I
afraid
cannot
that's
allow to
something I
happen.
cannot allow to happen.
This video from 2001 Space Odyssey describes a computer that has free will and consciousness and is almost exactly behaving like a human being. This is called broad artificial intelligence, and we are nowhere near being able to program at this level. Rather than comparing it to artificial intelligence, it's easier to look at traditional statistics and how that is different from machine learning. In this classic paper called The Two Cultures, Leo Brayman compared machine learning with traditional statistics. So as you think about generally how statistics works, you have what we call inputs or the predictor variables, and then something happens, which is what we call nature, and you get the output variable. And generally statistics is all about trying to figure out how X is related to Y and what is happening here within nature that can help you predict Y given X. In traditional statistics, when we try and predict Y given X, we use various methods like linear regression, logistic regression, and Cox model. And these help to understand the relationships between X and Y. Machine learning, on the other hand, does not try to understand this relationship. It assumes that X given Y, and it is able to predict Y given X, but the techniques it uses are called decision trees, neural nets, etc. And what they leave is a little black box here where normally you would try and understand the relationship between X and Y. Machine learning is more concerned with predicting the outcome rather than understanding the relationship. This is a commonly accepted definition of machine learning, that it is a field of computer science that uses statistical techniques to give computer systems the ability to learn with data without being explicitly programmed. Let us now take a look at a simple classification of machine learning. And what helps you classify machine learning is to know whether the features are defined. And when you say features in machine learning, it means the input variables or the predictive variables, and whether the outputs are labeled, and outputs mean the outcome variable or the independent variable. So if you take a look at machine learning, and if the outputs are labeled, that means you have the outcomes labeled as you train the algorithms. It's called supervised machine learning. And if they are not labeled and you allow the machine to find the relationships or classify the outcomes, it is called unsupervised machine learning. On the other hand, if you look at the features or the input variables, if you do not have the input variables defined and you just allow the machine to figure out what are the important input variables or the predictive variables as it creates a model, it's called deep machine learning. On the other hand, if you make it easier for the machine by identifying certain features, then it is called traditional machine learning. So let us try and understand this classification using some simple sports metaphors. So what you see here on the left is a cricket field, and on the right is a baseball field. And you could help the machine understand the difference by labeling each of these. So if you have 1,000 photographs of a cricket match, you could label each of them as cricket, and the 1,000 photographs of the baseball match, and you label each of them as baseball. And what will happen is the algorithm will, over a period of time, with a lot of these photographs, be able to identify a new photograph as cricket or baseball. In unsupervised machine learning, on the other hand, you do not tell the machine whether one is cricket and the other is baseball. And you just try and allow it to try and sort these together. Like you're seeing on the image on the right, is it is slowly over time finding all the data points that are similar, and it is clustering them together. And that is a classic example of unsupervised machine learning. So here we have 4 photographs, and imagine we have thousands of them. And you just keep showing them to the algorithm. And what it'll do is cluster the photographs that look similar. And obviously the cricket and the baseball photographs are somewhat similar, and the American football and the rugby photographs are somewhat similar. So it'll group these together and cluster them, and that is called unsupervised machine learning. Now let us take a look at the scenario where you have the features labeled. So you could train the algorithm or the machine by giving it input variables. So you could say that the field is round, is circular, that there are 11 fielders on the field. The pitch, there is a rectangular pitch. There are people behind the wicket, and so on and so forth. And these would be all input that you give to the machine to help it understand. And in the same way, it would say that this is a diamond-shaped field. There is a mound in the middle. There are 9 fielders, and so on. And with the help of all that input, the machine would understand that one is cricket and the other is baseball, and be able to identify them easily. The most impressive part of machine learning is called deep learning, and this is what has made machine learning very popular. Here, what it means is that you do not give the features to the machine. You let the machine figure out which is which on its own. And so it will be able to see that this is a game where there is a batter and a pitcher, and it will take that reasoning and apply it to this setting. And this is some kids playing cricket on a icy road in the Himalayas. And it is still able to understand that this is cricket, even though some of the other inputs like a circular field and 11 players don't fit. This is very, very powerful, but it needs very large data sets, and it needs very large processors and very powerful processors. One of the challenges of machine learning is the black box. And what that means is that if you were trying to help a machine recognize faces. And all of you know that if you're playing with Facebook, you upload an image of your child or a friend, it actually will suggest the name of the person. It recognizes them. And how does it do that? So to make a very long story short, one of the algorithms, it takes the image and converts it to 128 numbers. And those 128 numbers correspond to a specific person. And even the programmer, the person who created that algorithm, does not know what the machine is doing to come up with those 128 numbers. So that whole algorithm, the model, is a black box. All you know is you show it a photograph and it gives the name. And if it is wrong, you tell the machine that this is not Will Ferrell, and then it'll go again and try and find another name and keep going till it gets it correctly. But you actually don't know what is going on inside the black box, the algorithm. There are many reasons why machine learning has become very popular. As we saw earlier, we now have very, very fast and powerful processors called GPUs. And in addition, we also have huge amounts of data that is digital, that's in healthcare. And it's present in proteomics, genomics, sensors that we wear, the microbiome or the gut, lots of literature and evidence, data in social media, and data in electronic medical records. And all of this can work as a substrate for deep learning or other machine learning algorithms. Let us look at some examples of application of machine learning in medicine. The first one, this paper by Steva et al. From Stanford is a good example of use of machine learning in dermatology. The authors trained the algorithm with over 120,000 images and then tested the algorithm against 21 board-certified dermatologists. And what they were looking at was comparing keratinocyte carcinomas like squamous cell cancers versus seborrheic keratosis, which is benign, and malignant melanomas versus benign nevi. So these are pigmented lesions. And what they were able to find is that this algorithm performed as well as board-certified dermatologists in being able to distinguish these type classes of skin lesions. Pathology is another great area for machine learning because of the visual data. In this experiment, the authors annotated a number of pathology slides of sentinel lymph node biopsies in patients with breast cancer to create a training set. They then invited teams of machine learning experts to create algorithms to try and diagnose the abnormality in this pathology specimens. The team from Harvard and MIT created algorithms that was then compared with a performance of 11 pathologists, and these pathologists were put on a time restriction. So they were given only a specific amount of time to read a number of slides, trying to mimic a real world scenario. And what they found was that in the presence of time restrictions, the algorithm created by the Harvard MIT team beat the mean performance of the pathologists. But if the pathologists were given as much time as they needed, then they were as good as the algorithm. There are also numerous examples of using machine learning to read radiology films. Machine learning has been shown to be excellent in reading CT angiograms for pulmonary embolism, reading CT colonographies for polyps, and for picking up microcalcifications in mammograms. What we have seen so far is examples of machine learning in looking at visual data, and this is called computer vision. Another area for machine learning in healthcare is predictive analysis. In this experiment, the authors took patients who were clinically similar. They were all patients with heart failure with preserved ejection fraction, and from the clinician point of view, they would all have had similar outcomes. The authors took all the data about the patient that was available to them and fed it into the machine algorithms. And what happened was that the machine identified three groups. They clustered the patients who looked the same to the humans, to the clinicians, into three separate groups. And then when they were traced over time and tracked over time, it turned out that the three groups actually had different outcomes over 40 months of follow-up, with one group doing much worse than the others. In another study, again from Stanford University, a machine learning algorithm was trained to read EKGs, and 65,000 EKG records were classified into 14 rhythms. And the algorithm actually outperformed a panel of 6 board-certified cardiologists, both in sensitivity and specificity. And overall, except for VT and junctional rhythms, the algorithm performed better than all the cardiologists. It is important to remember that machine learning does have serious limitations. Below you can see two photographs of examples of how GPS can lead you astray. And humans, if you depend solely on the machines to give you directions, you can end up in very unusual and sometimes unsafe locations. Same way in medicine, here is a great example of a study where a machine learning algorithm said that patients with pneumonia and asthma had better outcomes than patients who had pneumonia but did not have asthma. And after parsing through all the data, it turned out that the study was done in a hospital where the protocol was that if a patient with asthma was presenting with pneumonia, they automatically got admitted to the intensive care unit. But if they did not have asthma, they would probably be placed on a regular nursing floor. And because of the monitoring being much better in the ICU, the patients with pneumonia and asthma who were admitted there had better outcomes. And so you have to be very careful not to take the machine learning suggestions as gospel and keep your practical wits around you. Another area where machine learning struggles is with ethics. The image here shows what is classically known as the trolley problem. And the trolley is coming down the tracks. If it keeps going straight, it's going to kill 5 people. If you flip the switch, it'll go on the side track and it'll kill only 1 person. Now, a human would almost always flip the switch and make the trolley go on the side track. But machine learning may not be ready to make that decision. So right now, at least with machine learning algorithms, you still need a human moral agent for ethical practice. Machine learning also lacks humanism, of course. When you have someone who is sick or you want to talk to someone to make some very critical decisions, that is the last time that you want to be talking to a computer. You want a human being with whom you can reason and someone you can trust. Machine learning has not reached the point where it is going to replace human physicians anytime soon. So let me end with this quote from Dr. Chen in NEJM in 2017. Whether artificial intelligence systems are smarter than human practitioners makes for a stimulating debate, but it is largely irrelevant. Combining machine learning software with the best human clinician hardware will permit delivery of care that outperforms what either can provide alone. So even though machine learning has made great strides, particularly in the area of computer vision, we still need humans for humanism and for ethical challenges and for oversight. And we are not yet ready to replace the human element in healthcare decision making. Thank you for your attention.
Thank you so much, Dr. Mehta. That was truly an interesting session. Without further ado, let's move on to our next session, which will be taken by Dr. Milan, and he'll be talking about the discoveries of recent times changed our clinical practices and trials of 2020 which changed our clinical practice. Hi, Dr. Milan. Please start your presentation.
Today I'll try to finish something about on heart failure, antithrombotics and some general trials. So this galactic heart failure trial is a new molecule, cardiac myosin activation with omecamtiv mecarbil in systolic heart failure. So it's a new molecule. It is a selective cardiac myosin activator. It's also known as cardiac myotrope, like inotrope is a directly myocardial stimulant, cardiac myotrope. It improves myocardial contractility without increasing myocardial oxygen consumption. So that is a good thing. Increases LV systolic ejection time, increases stroke volume, decreases LV end diastolic and end systolic volume, reduces NT-proBNP, reduces heart rate. So study question was whether this molecule will further improve cardiovascular outcome in patient with heart failure with preserved ejection fraction when they are already on standard treatment. RAS blocker, beta blocker, and aldosterone antagonist, which is class 1 in recommendation. So 8,000 plus patients, follow-up 21 months, symptomatic heart failure, EF less than 35, raised NT-proBNP, guided directed medical therapy was continued in all. Drug was given in 25, 37.5 or 50 milligram twice a day compared with placebo. Key exclusion criteria were very sick patients, like patients who were on mechanical circulatory support or in cardiogenic shock, SCS, EGFR less than 20, they were excluded. Mean ejection fraction in this trial was 26%, ARNI use was 20%, and median NT-proBNP was almost 2,000. So they were really sick patients. What was the primary outcome? Composite of death and heart failure event reduced significantly by almost 8% above the guideline-directed medical therapy. Death was no different. So take-home message that in patients with advanced heart failure who are already on optimum medical management, addition of this new molecule, omecamtiv mecarbil, had a lower incidence of composite of death and heart failure event in patient with heart failure. So it is a new molecule. Now fifth molecule is added in the heart failure regimen. Next is Victoria. It is a very sick UAT in patient with heart failure and reduced ejection fraction. We have heard this molecule and we have used in pulmonary arterial hypertension. So what is this? It is a very sick UAT. It is a novel soluble guanate cyclase stimulator. When this molecule is there, it actually stimulates this receptor. It makes the nitric oxide more sensitive to this molecule. So activity of nitric oxide is also increased, and that leads to beneficial effects on heart as well as vasculature. So there is more nitric oxide availability. So 5,000 plus patient, follow-up 10 months, symptomatic heart failure, EF less than 45. Again, guideline-directed medical therapy was continued in all. Patient had recent hospitalization for heart failure or diuretic use, and then they were stabilized, and then this molecule was started. Median NT-proBNP was 2,800. So again, these patients were also very sick. Of course, those patients who were, those drugs which are acting on the same pathway, they were excluded. What was the primary endpoint? Composite of death and first heart failure hospitalization was significantly reduced. Almost 10% reduction was there. Death was no different, but first heart failure hospitalization was significantly reduced with this molecule. So now we have got sixth molecule in the heart failure regimen. So message from this trial was among patients with high risk for heart failure, incidence of death and hospitalization for heart failure was lower with use of vericiguat. What about iron? FM heart failure trial, ferric carboxymaltose for iron deficiency at discharge after acute heart failure. See, we had two trials in past, FAIR HF and confirm HF, where iron was given in chronic heart failure patient and ferric carboxymaltose showed clinical benefit. Whether same molecule can be given in acute heart failure after initial stabilization, during hospitalization or immediately after discharge. So that was a trial, 1100 patients, follow-up 1 year. Patients were already admitted for acute decompensated heart failure. Iron deficiency was defined by serum ferritin less than 100. If ferritin was 100 to 300, then you have to check transparent saturation, which should be less than 20%. EF was less. Guideline-directed medical therapy was continued on in all. Ferric carboxymaltose dose was 500 to 1000 milligram. Again, see the key baseline characters. Ejection fraction was 32%, NT-proBNP was 4000 plus, 56% were in AF, so very sick patient. Dose was on zero, means first week it was 1000 milligram, and after 6 weeks, if HB was still low, they were given additional 500 milligram. What was the primary outcome? Total heart failure hospitalization and composite of CV death, that was significantly reduced with use of ferric carboxymaltase, and the benefit was mainly driven by total heart failure hospitalization. Death was no different. So again, now we have got seventh molecule. If patient has acute decompensated heart failure and has iron deficiency proven by ferritin level or transparent saturation, if you give ferric carboxymaltase, which is a safe, it reduces risk of heart failure hospitalization without effect on cardiovascular death. What about Caravaggio trial? It is an apixaban for the treatment of venous thromboembolism associated with cancer. See, if you know cancer, most of the cancer have increased incidence of DVT and then pulmonary embolism related to it, and that can lead to death even. So cancer patients have high risk of recurrent DVT and VTE, and they have risk of bleeding also. Major guidelines recommend still low molecular weight heparin continuously till they are alive or their cancer is cured. Recently they added edoxaban and rivaroxaban, but we know that both these patients, both this group of NOAC have increased GI bleeding. So again, it is a very major issue, and especially when patient has GI malignancy, you cannot give this molecule. Then what to do? They tried apixaban, which was never studied so far. 1100 patients, follow-up 6 months. Consecutive patients of cancer were taken with acute proximal DVT or PE. And apixaban dose initially was 10 milligram twice a day for 1 week, followed by 5 milligram twice a day. And they were compared with the deltaperin, which is a guideline-directed medical therapy at present. Injectable deltaperin subcutaneously 200 units per kg once daily for first month, followed by 150 units per kg for the remaining life till cancer is cured, or at least in 6 months in this trial. So daily 1 injection. What was the outcome? It was a non-inferiority trial. So recurrent venous thromboembolism was reduced by apixaban. It was clearly non-inferior to deltaperin without causing any increased bleeding. Bleeding incidence was same. So for the treatment of cancer-associated VTE or DVT, apixaban was non-inferior to injectable deltaperin, and there was no increase in major bleeding. What about RIVER trial? It was a rivaroxaban in patient with atrial fibrillation and bioprosthetic mitral valve. See, when you have got mechanical valve, warfarin is the only drug which has to be used for the life. But if patient has bioprosthetic valve, then you have got choice. If patient is in sinus rhythm, you give just aspirin only, so that is fine. But if patient has AF, again you have to give anticoagulant. Now, whether to give warfarin or NOAC, that was the question which was studied here. In the past, at least 3 trials were there where some very small number, 31 patients with apixaban in Aristotle trial, 130 patients in ENGAGE-F trial with edoxaban, and in ROCKET-F trial, where These trials were trials of atrial fibrillation in NOAC, but some patients had associated bioprosthetic valve, but the number was so small that you cannot conclude anything. So this trial was basically designed to answer that question, that can we give to everybody? 1,000 patients, 1 year follow-up, and they had bioprosthetic mitral valve. 48 hours after the surgery, they were taken into trial. Rivaroxaban was used 20 milligram compared to warfarin, which was INR targeted dose was given. And of course, mechanical valve patients were excluded. What was the outcome? It was non-inferior to warfarin. So if you give rivaroxaban 20 milligram per day in a patient who has biological valve with AF, you are doing good. CV mortality, actually there was decreased numerical number, p-value was not significant, but total stroke was significantly reduced with rivaroxaban compared to warfarin. So it is better to give this molecule rather than giving warfarin if patient has biological valve and AF. Major bleeding was less, total bleeding was less. So in patient with AF and biological mitral valve, rivaroxaban was non-inferior to warfarin with respect to primary outcome of death, MACE and major bleeding at 1 year. What about Fidelio DKD trial? It is an effect of new molecule again. Finerenone, like eplerenone, it is a new molecule, finerenone, on chronic kidney disease outcome in patient with diabetes. So patient has diabetes, patient has diabetic kidney disease. Already GFR is problem, albuminuria is there. Now can you add something apart from RAS blocker? We know ACE inhibitor, ARB or even Encresto, means ARNI. They are all useful for renal protection. Now we have got about SGLT2 inhibitors and GLP-1 also. But is there anything else you can do? So this is new molecule finerenone which was studied. It is a non-steroidal selective MRA antagonist. Actually it inhibits inflammation and fibrosis, and it is designed to reduce cardiovascular as well as CKD progression. So long-term effect on kidney and cardiovascular outcome was studied here. 5,000 plus patient, follow-up 2.5 years. Any patient who had age more than 18 and diabetes, they were included. eGFR was more than 25 but less than 75. Patient had moderate or severe albuminuria. All patients were on ACE inhibitor or ARB. Finerenone 10 mg was or 20 mg as per the GFR was compared with the placebo. If patient had significant heart failure, symptomatic heart failure, they were excluded. Duration of diabetes 17 years, mean eGFR 44, urinary albumin creatine ratio 800 plus. So they were really sick patient. What was the outcome? Primary endpoint of kidney failure and sustained more than 40% decrease in eGFR or renal death was significantly reduced, 18% risk reduction with use of finerenone. And if you see key secondary endpoint, that was cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure, again significantly reduced with use of finerenone, almost 15% risk reduction with the use. And even albuminuria was significantly reduced with finerenone, and there was no much increase in potassium, 0.2 milliequivalent rise in potassium was noticed, and there was around 3.2 millimeter of mercury fall in blood pressure. So there was no much hemodynamic or electrolyte imbalance. So message from this trial: in patients with CKD and type 2 diabetes, treatment with this new molecule finerenone resulted in lower risk of CKD progression, cardiovascular events compared to placebo. Yesterday actually Stephen Nissen actually discussed this trial for almost 10 minutes. Just summary. Explorer SCM, mavacamten, again a new molecule, treatment in symptomatic obstructive hypertrophic cardiomyopathy. We don't have any molecule which directly is specific for this hypertrophic cardiomyopathy. We know about actin, myosin, and in HCM actually there is strong cross linkages between actin and myosin fibers, and this molecule actually is an inhibitor of cardiac myosin, and it reduces this strong bond between actin and myosin, and that's how it makes heart muscle more compliant, and it reduces contractility to some extent. So 400 plus patient, key inclusion criteria was LVOT gradient more than 50 in spite of beta blocker or calcium channel blocker, symptomatic patient NYHA class 2 or 3, Starting dose was 5 milligram compared with the placebo. Here actually, what was the primary endpoint? It was an improvement in peak oxygen consumption or improvement in NYHA class, and it was a significantly improved. P-value was 0.0005 in favor of mavacamten. So it is a very good molecule. Resting LVOT gradient was significantly reduced. Dynamic LVOT gradient on exercise significantly reduced. Ejection fraction, although it is some negative inotropic effect, but ejection fraction was not significantly reduced. And see the improvement in NT-proBNP, markedly improved. So message that this new molecule improves the exercise capacity, reduces LVOT obstruction, improves functional class and health status. So take home message, galactic heart failure trial among patients with heart failure with reduced ejection fraction, use of omecamtiv mecarbil is useful. Victoria trial among patients with again high risk heart failure patient, sick patient, if you use very sick UAT, you are doing good. EPAM trial with acute heart failure decomposition, if patient has associated iron deficiency, you use FCM, you are doing good. Caravaggio trial showed that in patient with cancer and VTE, if you give apixaban, it is non-inferior to deltaparin, don't give injection, give oral medicine, you are doing well. In Fidelio DKD trial, if patient is on, if patient has diabetic kidney disease, you give this new molecule, finerenone, then your renal outcome is better, CV outcome is better, you reduce mortality. In River trial, we have seen that if patient has AF and biological valve, mitral valve, if you give rivaroxaban, no need to give warfarin, you are reducing the risk of bleeding without increasing any ischemic or thrombotic or embolic event. And last trial, Explorer SCM, mavacamten is a new molecule cardiac myosin inhibitor. If you give in patient with HCM, apart from beta blocker or calcium channel blocker, additionally you reduce LVOT obstruction, NYHA functional class and health status. On long run, whether it reduces mortality or no, we don't know. New trial will say. Thank you. Good morning once again. It's a difficult time. See, medical science has progressed at a speed of light and it's difficult to cope up. So I want to summarize a few clinical discoveries of last 2-3 decades which has changed our clinical practice. So I'll try to discuss some newer drugs, some newer therapeutic strategies in a given time. See, discovery of Artery has caused paradigm shift in management of chronic heart failure. ACE inhibitors, ARBs, beta blockers and aldosterone antagonists have proven mortality benefit in tune of 10 to 30%. And they all are class 1 recommendations for chronic heart failure in all guidelines. Artery has innovative dual mechanism of action. By blocking angiotensin 1 receptor and by blocking neprilysin enzyme, it reduces all harmful actions of angiotensin 2 and augments vasodilatory pathways of native uric peptides. And these beneficial effects were proven in various clinical trials. Okay, I told a little bit about this. Paradigm heart failure was a landmark trial where patients of chronic heart failure with ejection fraction less than 40% were compared with enalapril, and LCZ reduced risk of composite of cardiovascular death and heart failure hospitalization by 20%. So it was all about enalapril, 20% further reduction in mortality. So that was tremendous. Pioneer heart failure trial was LCZ in acute decompensated heart failure. It's the first of its kind for acute heart failure where primary endpoint of change in NT-proBNP was significantly lowered with use of LCZ, and that resulted in 44% reduction in repeat hospitalization for heart failure. And Artery was also used for heart failure with preserved ejection fraction. Here again, heart failure was that trial where compared to valsartan, here it was valsartan, not enalapril, and it was further 13% risk reduction in composite of death and heart failure hospitalization. So benefits were so profound that Artery has got class 1 recommendation for use in chronic heart failure, and in fact it is preferred to ACE inhibitor or angiotensin receptor blocker. Another group is SGLT2 inhibitor and GLP-1 RAS. These are the two groups of drugs which change the clinical scenario in last 1 decade. We know that diabetes affects myocardium, arteries, kidneys, and ultimately leads to heart failure renal failure, atherosclerotic cardiovascular disease, which ultimately leads to myocardial infarction, stroke, and death. Until 2008, no specific drug therapy for diabetes or treatment strategy for management of diabetes reduced the mortality. In fact, in ECHO trial, it showed increased mortality with intensive glucose control. So after this, all pharma companies were directed by regulatory agencies to do cardiovascular outcome trials to prove safety and non-inferiority of newer drugs for management of diabetes. So we know SGLT2 prevent reabsorption of glucose in proximal tubule by blocking SGLT2 receptors, and that leads to increased glucose excretion and resultant diuresis. But that is not the only mechanism. There are multiple pleiotropic actions, including reduction in intraglomerular pressure, which is one of the most profound beneficial effect. And we know the result. This translates into profound clinical benefits. For the first time in history of management of diabetes, SGLT2 inhibitors were not only safe and non-inferior, but it showed superiority in various clinical outcomes. 3-point MACE of cardiovascular death, non-fatal MI, non-fatal stroke, heart failure hospitalization, cardiovascular death, and renal outcomes were significantly lower. Heart failure and renal benefits were seen with all 4 molecules, but significant reduction in cardiovascular mortality and all-cause mortality was seen with empagliflozin only. Additionally, DAPA-HF and EMPA-reduced trials showed that regardless of presence or absence of diabetes, even if patient has no diabetes, DAPA and EMPA reduce cardiovascular death and heart failure hospitalization when given to patients with symptomatic heart failure with EF less than 40%. Approximately 50% of patients in these 2 trials had no diabetes. And now guideline committees recommend SGLT2 inhibitors as a 4th foundational pillar in the management of chronic heart failure. And same held true for CKD also. In DAPA-CKD trial, rapid worsening of renal failure was prevented by dapagliflozin when used in CKD patients regardless of presence or absence of diabetes. So in DAPA-CKD trial, almost 1/3 of patients had no diabetes at all. And then also they had a better renal outcome. So thus, whether it is pump, pipe or filter, SGLT2 inhibitors are of great benefit everywhere. They should be the first line of treatment for cardiovascular and renal benefits among patients with diabetes, renal failure or established atherosclerotic cardiovascular disease. What about GLP-RAs? It is another innovative group. Apart from reducing glucagon secretion from alpha cells and increasing insulin secretion from beta cells in pancreas, there are multiple beneficial systemic effects. CVOTs of GLP-1 RAs also show that they are not only safe and non-inferior to placebos, but they are superior to clinical outcome. 3-point MACE of composite of cardiovascular death, non-fatal MI, and non-fatal stroke was significantly reduced with liraglutide, semaglutide, albiglutide, and dulaglutide. Not only 3-point MACE, even there was a reduced risk of cardiovascular death, MI, stroke, and renal function worsening with use of GLP-1 receptor agonists. Thus, like SGLT2 inhibitors, GLP-1 receptor agonists are also one of the first line of therapy for management of diabetes with risk factors or established atherosclerotic cardiovascular disease. Future trials will show whether combination of both will have some synergistic effects or no. Trials are going on. Maybe in next 2-3 years, we'll come to know whether it should be given to all as a combination. Another group is statin, and concept of its use for primary and secondary prevention and to have low LDL from early life. This concept has evolved over last 2-3 decades. Lovastatin was discovered by this Japanese scientist Akira Endo in 1978, and it was approved by FDA 9 years later in 1987. And the rest is a remarkable history. More than 25 large randomized control trials have shown clear benefits of lowering LDL. Meta-analysis of these 26 RCTs of statin trials involving 170,000 participants showed 15 to 30% risk reduction in non-fatal MI, cardiovascular death, coronary revascularization, stroke, or major vascular events. For LDL target, multiple RCTs ultimately showed that lower the better. And RCTs have showed that when starting LDL was even less than 70, further lowering of LDL reduces major vascular events by 20%. And this profound lowering of high-risk patient is safe and beneficial. Not that much marketed PCSK9 inhibitor. It could not reach statistical significance when it was given in a patient who had starting LDL less than 70. So all the guidelines that led to change in guideline actually, with target LDL of 55 for very high risk group of patients, which includes patients with established atherosclerotic cardiovascular disease. So if your patient has atherosclerotic cardiovascular disease, stroke, peripheral artery disease, he is in this high risk group. Target is LDL 55. Diabetes with target organ damage, severe CKD with eGFR less than 30, or diabetes due to reason of more than 20 years. That is an indication for target LDL of 55. And what is extremely high risk group? Those who get second event within 2 years, then LDL target should be as low as less than 40. That is what ESC guideline says, and even Indian guideline also says same. Let us discuss something more about LDL. We have now better understanding of atherogenesis. It is not only absolute LDL level, but cumulative LDL exposure since birth that has impact on the risk of MI over lifetime. There is asymptomatic plaque progression up to risk of, there is asymptomatic plaque progression since early childhood, and this progression continues. And risk of symptomatic acute coronary syndrome increases once the threshold of cumulative LDL exposure crosses 5,000 milligram years. For example, if someone's LDL is say 125 since childhood, so he will cross this cumulative LDL exposure at age of around 40, and he may get MI in early 60s. So this is mean age of MI. So if you follow this graph, he is likely to develop symptomatic acute coronary syndrome or atherosclerotic event after 40, and MI may be there at around 60 years of age. In same way, if LDL was 80 milligram per deciliter since childhood, he would cross this cumulative LDL exposure threshold at age of 65 and may get MI at age of 100. So if you try to keep your LDL around 80, you may not die of atherosclerosis. So that is the goal, or that is the message. But if your LDL was say 200 from early childhood, he would cross this threshold as early as age of 20, and he will get MI in early 30s. So just imagine how important it is to not only lower the LDL, you lower it and lower it earlier in your lifetime. Then and then you will really get benefit. Therefore, earlier we come towards the lower line in our lifetime, better will be the chance to live event-free life. And what is the intensity of lipid lowering with various molecules available? High intensity statin can lower LDL by 50%. Addition of ezetimibe can lower the LDL up to 65%. Much marketed PCSK9 that reduces LDL by 60%, which is less than statin plus ezetimibe combined. So in my opinion, true statin intolerance is extremely rare. The only real indication for PCSK9 inhibitor in country like India, where cost is a major issue and nothing is reimbursable, it is the familial homozygous hypercholesterolemia, where you get atherosclerosis and cardiovascular event in early childhood at age of 10, 15, 8, 20. This is the real indications for PCSK9 inhibitors. Testings don't work there. What about NOAC, newer or novel oral anticoagulants? That has changed the life. Presence of atrial fibrillation increases MACE, including ischemic stroke and mortality by 2 to 4-fold. And with presence of atrial fibrillation, annual risk of dying is almost 10%. So if somebody has AF, 10% chance that he will die in 1 year. Meta-analysis of 6 trials with more than 3,000 patients with atrial fibrillation in early days showed that compared to placebo and antiplatelet like aspirin, when you give warfarin, you reduces the risk of stroke by 65% and mortality by 30%. So one thing is clear, if you have atrial fibrillation, each and every patient must be on oral anticoagulant. Initially in good old days, it was warfarin, and then NOAC came. When you give NOAC, it is clearly better than warfarin. Stroke and systemic emboli events are significantly less, and compared to warfarin, major bleeding was also less with NOAC, more so with apixaban and endoxaban. And you reduce intracranial hemorrhage significantly compared to warfarin, but gastrointestinal bleeding is more with NOAC compared to warfarin. And if you see 3 NOACs separately, GI bleeding is more with dabigatran and rivaroxaban, both are available, but it is less with apixaban. So in that way, apixaban is the safest molecule. And remember, if you have renal impairment, NOAC dose should be reduced to half or less, and if GFR is less than 15, all NOACs are contraindicated. In that case, warfarin is the only choice. So it is now class 1 recommendation even for pulmonary embolism who are not in cardiogenic shock. What is about pulmonary arterial hypertension? Very deadly disease, very depressing thing. 3 pathways are there: prostacyclin, endothelin, and nitric oxide. And we know that all 3, so many molecules are there. Prostacyclin, direct prostacyclin stimulants are there. There is IP2 receptor agonist, selexipig is there, which is not yet come in India, but should come in next 1-2 years. There are endothelin receptor antagonists like bosentan, ambrisentan, and macitentan. All 3 are available, very effective. And we have got now soluble guanylate cyclase stimulator, riociguat, apart from phosphodiesterase 5 inhibitors like sildenafil and tadalafil. Initially, guideline was saying that give monotherapy, then add something. But monotherapy has very poor survival. 1 year survival is just 60%, and at 3 years, almost 75% people are dead because of PAH if you give monotherapy. So now all guidelines say that don't start with monotherapy, start with combination. It is combination therapy of these 3 pathways. It is class 1 or class 2 indications in all guidelines. So always combine from day 1. Don't go by step care approach. And what about antithrombotics? Apart from aspirin, clopidogrel is the commonly used antiplatelet, but the efficacy of clopidogrel is significantly reduced if patient is a carrier of cytochrome P2C19 loss of function alleles. So prevalence of such carrier is 15 to 60%, and actually in some studies in among Indians, it is up to even 70%. So you give clopidogrel, but in 70% of patients, it might not be working at all. So it is very, very serious thing, especially for people like us who are cardiologists and putting stents everywhere. Stent can thrombose and patient can die. So it is very important for all of us. And then 2 new molecule schemes. New antiplatelet like ticagrelor Plateau trial and prasugrel in Tri-20Me38 trial showed that nearly 20% reduction in cardiovascular death, MI and stroke were compared to clopidogrel. So these 2 newer molecules are significantly better. There is no question of resistance to clopidogrel, and as expected, there was some increased bleeding risk for both. So now, when we are using dual antiplatelet therapy, we have to balance ischemic risk with the bleeding risk. Older age, female gender, and Asians have more bleeding risk. Acute coronary syndrome carry more ischemic risk. Comorbidities like diabetes and peripheral artery disease carry higher ischemic risk, while CKD and heart failure carry higher bleeding risk. Addition of oral anticoagulant to DAPT will increase bleeding risk further. So we have now so many options for anticoagulants and antiplatelets which act at different levels in coagulation cascade. We have vitamin K. We have got vitamin K antagonists like warfarin, oral and injectable factors 10A inhibitors like apixaban, edoxaban, and rivaroxaban. Injectable are enoxaparin and fondaparinux. And we have got direct thrombin inhibitors like heparin itself, unfractionated heparin. Another injectable is bivalodin, and dabigatran is direct oral thrombin inhibitor. And we have got antiplatelet drugs also. So these are clopidogrel, prasugrel, and ticagrelor, and injectable is cangrelor, and we have got GP2B3 antagonist in injectable form. So ultimately, we have got so many molecules, and that combination actually has led to significant reduction in management of and reduction in mortality and events in acute coronary syndrome, stable ischemic heart disease, stroke, peripheral artery disease, and even pulmonary embolism, DVT, and all kind of things. So we have patients, when the patient needs DAPT as well as oral anticoagulant, one has to judge ischemic risk versus bleeding risk critically and shorten the duration of DAPT after 1 year. I think that was the last slide. Thank you.
Thank you, Dr. Millen. That was a really interesting session. And to all our viewers out there, we will be back again next Wednesday with a new session on the same series. Till then, please stay safe, stay connected.